It's now
So,
live.
thank you very much, Ava. Good morning, good afternoon, good evening, everyone, wherever you are in the world. Thank you very much for your support of the programme and Diagnexia's support of the programme. But most importantly, this week, I need to thank Dr. Jenny Stahle, who is a colleague of mine through the Pathological Society of Great Britain and Ireland. Jenny trained in histopathology in Leeds, just across the Pennines from Manchester. She took up a consultant post in Dundee, where she specialises in endocrine pathology and also hematopathology. So she had asked whether she should talk about endocrine or hematopathology. Obviously, hematopathology is close to our hearts, but we know that you have a lot of that through the programme anyway. So today we're very grateful that she's talking about parathyroid and adrenal neoplasia. These are complex conditions, particularly the adrenal neoplasias and pheochromocytomas and so on can be very difficult to diagnose, particularly in biopsy work. I know that from experience in the past. So very grateful for Jenny's input. Jenny is just in the process of moving back to Leeds as a consultant in Leeds from Dundee. I am on late vacation at the moment, so I'm travelling a bit this morning, so it may not be possible for me to be at the end, so apologies for that. Given that, and without taking too much more of Jenny's time, Dr. Zaid Husef will be talking on Hodgkin lymphoma next week. It is a recording because I'm on leave, but I will be around to answer questions, and it is in fact an excellent talk. That's why we're rerunning it. The week after that is Dr. Lena Kimona, who's a neuropathologist, talking about pathology of dementia and neurodegenerative conditions. And these will all be at the normal time, wherever your location is on a Wednesday. Again, in case I'm not here at the end because of my travel plans today, it's a little fluid, as you can imagine, in different parts of the world. Thank you very much to Diagnexia and Ava and to Jenny. So without further ado, I will pass over to Jenny. Thank you very much.
Thank you so much, Richard, and thank you everyone for having me here today. It is a genuine pleasure to get the chance to share a couple of subjects within endocrine pathology that I feel don't get a lot of love. So we're going to do a little bit of a split session today. We're going to start with some parathyroid and we're going to move on and do a bit of adrenal neoplasia as well. So in a sort of broad general pathology general practice setting, you may find that you aren't encountering a huge volume of primary adrenal neoplasms. So we're just going to sort of run through the basics, come up with a bit of a strategic diagnostic approach to these things, and we're going to have a look at some of the grading systems involved in various neoplasms, and we're going to have a look at some of the recent changes in the WHO fifth edition as well. I think I just pretty much said that, but it's always a little bit tricky with resident teaching, sort of knowing where to pitch it. So I like to start anything off with just a little overview of normal. Then we'll talk about parathyroid adenoma. We'll talk about hyperplasia. We'll talk about the distinction between the two. And we'll talk about when it goes over the line to carcinoma. And then we'll do the same for adrenal. We'll do a quick overview of normal, and we'll talk about sort of your three main neoplasms that you're likely to encounter. So adrenal cortical adenoma, adrenal cortical carcinoma, and of course pheochromocytoma. And we'll do a little honorary mention at the end of paraganglioma, although it's not strictly adrenal. So parathyroid glands, usually anatomically located, four of them superior and inferior on each lobe of the thyroid, although the locations can vary. You can also get intrathyroidal parathyroid or ectopic parathyroids as well. And with parathyroid particularly, it's good to have your a good solid grounding in what your normal range is. So anything that's over 6 millimeters, we would class that as enlarged. And with parathyroid gland at cut up, I always weigh to 2 decimal places. So any gland that's weighing more than 60 milligrams, we would class that as abnormal as well. Another important aspect that we'll go onto on the microscopy is the percentage of fat. So usually 17%, rarely more than 50%. Women tend to have more um, percentage fat than males. So that's another thing that kind of closes in if we've got sort of complete absence of fat. And in terms of our other kind of normal feature that we want to look for is intracytoplasmic lipid. So at cut-up, we'll be focusing obviously on the size and the weight and the macroscopic appearance. I always embed the entirety of the tissue for parathyroid, and I tend to just ink them one colour and bread slice them through. And once we sort of get down the microscope, we're really looking at three main cell types. We've got our chief cells, we've got our oxyphilic cells, and as mentioned, we have our adipose cells as well. So the chief cells are the functional cells of the parathyroid, and they are responsible for the hormone synthesis and release. So they contain calcium sensing receptors. And your parathyroid hormone is essentially what is regulating your serum calcium. So it's going to promote the release of calcium and phosphate from bone, increase production of vitamin D, enhance intestinal calcium absorption, and decrease calcium loss in urine. So essentially, when your calcium levels fall in the blood, then that triggers the release of parathyroid hormone, which restores calcium homeostasis, and pulls the blood levels back up. And then if it goes too far the other way, that's when the calcitonin kicks in from the thyroid gland and brings it back down again. So this is fairly normal looking parathyroid gland, and probably the most immediate and striking feature is that you've got this very random admixture of adipose cells in and amongst chief cells, and they tend to be quite vascular as well. So if you're seeing this amount of fat, that's quite reassuring from a sort of normal morphology perspective. And these are our chief cells. You can see they have sort of very ovoid, round, uniform nuclei. You can see the nuclear size in relation to the erythrocytes, and they tend to have quite sort of pale cytoplasm. And then additionally, we have these oxyphilic cells. So they're essentially when you have more mitochondria in the cytoplasm, the cells take on a more amphiphilic or oxyphilic look, and that is often seen in age-related changes, and it's often seen incidentally in neoplasia as well. So here's an oxyphilic nodule within largely kind of normal parathyroid. Just some more close-up high power view of normal chief cells admixed with adipocytes. And again, sometimes you'll see these kind of pseudo-follicular looking spaces, and it's just important to make the distinction. Sometimes they can morphologically even mimic thyroid follicles, and it's important to, especially when dealing with sort of intrathyroid or parathyroid, it's important to be able to recognize that this is a feature and it doesn't represent thyroid tissue. So about 85 or over 80%, 85% of primary hyperparathyroidism are related to parathyroid adenomas, and 10% of those are hereditary. So they're often associated with specific tumour syndromes and mutations. So MEN1, MEN2, MEN4, and hyperparathyroid jaw tumour syndrome. This one is a pretty chunky example. And they tend to be very circumscribed, very cohesive. And when we look at them under the microscope, I hope what immediately stands out is that we have this rim of appreciably normal parathyroid tissue, and then we have this very sort of thin demarcation of capsule, and then we have mostly chief cells, a few oxyphilic cells, and largely absent fat, and that's very characteristic of parathyroid adenoma. And you may, when you come to sort of trawl through on high power, you may find that you're seeing a little bit of nuclear variation. So there is a uniformity to the nuclei, but there is a little bit of variation in chromasia. There's a little bit of variation in size, and that's within acceptable limits in benign parathyroid neoplasms. And you may also see as well that you have a mix of chief cells and oxophilic cells. You may have an oxophilic dominant population, you may have a chief cell dominant population. So this is an example of a more oxophilic parathyroid adenoma, where virtually the entirety of the neoplastic cells have that really bright pink cytoplasm. It's got that very, very oxophilic pink appearance to it. So if that is the dominant feature, then you would describe that as an oxophilic variant. And similarly, we have one that's more predominantly chief cell. And I think, again, it's important to be aware that you are allowed a little bit of nuclear variation and nuclear atypia in these. You can see here there is quite a difference in nuclear size across some of these cells, but this is all still perfectly within the limits of a benign entity. And if you were to do a Chi-67 on this, it would still come out very, very low. So when we talk about parathyroid adenoma and hyperplasia, how do we tell the difference? Because usually on the form it says query adenoma, query hyperplasia. And to be honest, they look histologically identical. So the conventional wisdom used to be if it was a single entity, then we would say it's in keeping with an adenoma, assuming normality or suppression of the remaining glands. If more than one gland was affected, then we would call it hyperplasia. But there's a little bit more of a grey area now in the WHO 5th edition. So it describes that you can actually get multiple adenomas in some syndromes, like hereditary hyperparathyroidism. So these are recognised as multiple adenomas and not hyperplasia. So it's important to just be aware if there is some sort of background syndromic context when you're making that distinction between adenoma and hyperplasia. Primary hyperplasia is thought to be rare, and then secondary or compensatory hyperplasias tends to be associated with physiological stimuli, so things like low serum calcium, high serum phosphate, or vitamin D deficiency. So parathyroid carcinomas are rare. They make up less than 1% of primary hyperparathyroidism cases. About 15% of patients with HPT-JT will develop it, so it can be familial. It can also be sporadic, and it's usually associated with deletion or inactivation of CDC73, which codes for the parafibromin tumor suppressor protein. So again, the 5th edition has quite nice, neat diagnostic criteria. So you need a parathyroid tumour which shows at least one of the following: angioinvasion, lymphatic invasion, perineural invasion, invasion of adjacent structures and organs, or regional or distant metastasis. And I would say of all of these, probably invasion of adjacent structures is often the one that trips people up, because if you have incomplete excision of a parathyroid adenoma, then you really have no way of seeing what it's doing at the boundaries. So often when we are diagnosing parathyroid adenoma on an incomplete excision, we'll say it's in keeping with parathyroid adenoma. There's no other adverse features, but just with the caveat that we're not able to evaluate it relative to adjacent structures. So this is a nice example of frank invasion of a parathyroid neoplasm into the adjacent thyroid tissue. So what we have here is a chief cell predominant tumour, and you can see here immediately that this is not within any kind of nice, neat boundary. This has completely gone walkabout. You can see even on low power, we've got either angioinvasion or lymphatic invasion. It's within some kind of endothelial line space. And you can see that we've got tumour essentially just bursting out and frankly invading into the thyroid parenchyma, which is over here. So if all of our parathyroid carcinoma cases were this easy to spot, then it wouldn't be a difficult diagnosis to make, but it can be a bit more subtle. This is a nice example of perineural invasion in a parathyroid carcinoma, and as well, just to appreciate that while we do have nuclear variation in parathyroid adenoma, by contrast, this parathyroid carcinoma does look much wilder. We do have these sort of slightly necrobiotic looking cells. There's a bit of disc cohesion. There's variable nuclear chromasia. There's more marked anisonucleosis. And of course, it's wrapping around the perineuron of this nerve structure here. I just want to pause for a moment though and talk about cytological atypia within parathyroid carcinoma, because it's one of those slightly frustrating areas where it's very variable and it's not an absolute requirement for malignancy. And I just want to sort of illustrate these two side by side. So this is parathyroid carcinoma, and you can see that it is because we've got vascular invasion here. So this is a frankly invasive tumour. But if you look at the cytology here, if you look at the nuclear morphology, that's quite uniform. There's not really a whole lot that would clue you in. If you were to ignore the bottom half of this, there's not really a lot that would clue you in that this is malignant versus an adenoma. So it's really, really important to examine the periphery of every parathyroid adenoma and make sure that to the best of your ability, you are ruling out areas like this of vascular or lymphatic invasion, of growth into the surrounding structures. And then by contrast, we have something that's much wilder looking here. We've got, this is heavily mitotically active. It's very frankly pleomorphic. So there's a huge, huge spectrum of nuclear variability. And often in diagnosing malignancies and carcinoma particularly, we rely on we rely on nuclear pleomorphism. We rely on things looking wild to give it that, to push us over the edge to suspect malignancy. But parathyroid neoplasms are one area where that's not particularly helpful. So immunohistochemically, you would expect parathyroid carcinoma and indeed adenomas to express your standard parathyroid immunohistochemical profile. So it should express PTH, GATA3 and neuroendocrine markers. And the carcinoma will often show, if it's a stain you have available, we actually don't have it in Dundee, but it will often show loss of parafibromin. The Ki-67 increases can be relatively modest. So even an increase of a Ki-67 over 5% is enough to sort of clue in that this is perhaps not behaving in an indolent way. So we have adenoma and hyperplasia on one end, we have parathyroid carcinoma on the other, but what do we do if we have something that looks weird, but we can't get it over the line for carcinoma? Because this is another really common emerging field of discussion in endocrine pathology in general. And it's really, what do we do with all of these tumours that don't neatly fit into a benign or malignant category? So there's a new term within the WHO 5th edition called atypical parathyroid tumour. And it's essentially an UMP, a tumour of uncertain malignant potential. And it's quite analogous to things like your thyroid follicular tumour of uncertain malignant potential, in the sense that it's a neoplasm where you have a degree of concerning either cytological or architectural features, perhaps extension into the capsule, but it's not through and through, it's not out into the surrounding tissue. And I think this is a fairly new term, and I would approach it with caution and try not to overuse it, because you can get variation in appearance in just normal adenomas. You can get occasional readily identifiable mitotic figures. And I think it's important not to jump into calling every slightly odd adenoma an atypical parathyroid tumour. But having said that, especially where you have that sort of beginning of extension into the capsule, but it's not made it all the way through, this can be a really useful category just to trigger closer follow-up. With that being said, with any atypical parathyroid tumour, it's not a diagnosis that I would make without sort of getting multiple levels through the section, just to make sure that this, if you do have what looks like early extension into a capsule, it's not entirely uncommon to level through and find that it's actually breached at a deeper level. So it's another reason why it's really important to submit the whole gland for processing, and examine it as thoroughly as you can, and make liberal use of levels where you can. So this is just an algorithm that I quite like in terms of triaging parathyroid tumours with worrisome features. So just going into a little bit more detail of what might be a red flag for you. Sort of if you've got thickened connective tissue around your nests, if you've got tumour cells going into the capsule, if you have adherence to adjacent structures, but you're not quite there with frank invasion. Band-like fibrosis tends to be a bit of a red flag as well, and a trabecular growth pattern. Now, none of these necessarily mean automatic malignancy. The same with increased mitotic activity, atypical mitotic figures, coagulative necrosis as well. That tends to, I don't see that very often, but it is listed as it would make you raise an eyebrow if you saw it. Parafibromin loss, if you have that immunohistochemistry available to you, and a Chi67 labeling index that's over 5%. So if you have all of these, and you also have angioinvasion, lymphatic invasion, perineural invasion, invasion of adjacent structures, or METs, then you're over the line and you're into parathyroid carcinoma. But if you don't have those diagnostic criteria for malignancy, but you have other worrisome features, then that keeps you in the ballpark of an atypical parathyroid tumour. So we've just made it halfway through, and I'm going to pivot to adrenal gland. I just wonder if it might be worth pausing for a moment to see if there's any questions on parathyroid while it's fresh. Is that okay, Ava?
Absolutely. I don't see anything in the chat, but maybe people will put something in.
Okay, perfect. I can't see the chat because my PowerPoint's on full screen, so if any, feel free to interrupt me with any questions. Okay, so that's a kind of whistle-stop overview of what I would consider to be the main diagnostic issues in parathyroid pathology. And I would like now to move on to adrenal gland and do something similar. So again, primary adrenal neoplasms may not be something that you have the chance to encounter very much, or maybe you get loads of them. We tend not to get huge amounts, but I think I think we can we'll just start with our basic normal histology, and then we'll look at we'll look at neoplasms that arise from various areas of the gland. So you've got your adrenal cortex, which is your outside bit, and that's your adrenal cortical cells. So those arise from the mesoderm, and they're responsible for various hormone productions. So aldosterone, cortisol, androgens. And then you've got the inside bit, which is your adrenal medulla, and that's your chromaffin cells or pheochromocytes. And those are neurocrest in origin. They arise from the ectoderm. And they're responsible for your catecholamine secretion. So within the gland, we have various sort of zones of the cortex. So this is your external aspect, which is surrounded by a thin fibrous capsule. Then you have your zona glomerulosa, your zona fasciculata, and your zona reticularis. And you can appreciate the change in the, particularly the staining of the cytoplasm of these cells as we go through the different zones. And then in here, we can see the adrenal medullary cells are quite distinct. They have a much sort of larger nucleus, a slightly more powdery look to them, whereas our cortical cells tend to be sort of more small, round and ovoid in nuclear detail. So each zone kind of has its own thing that it's responsible for producing. So your zona glomerulosa is responsible for predominantly aldosterone production. Your zona vesiculata mainly produces glucocorticoid, but also a small amount of androgens. And then your zona reticularis is mainly androgens with a small amount of glucocorticoids. So this is just another example of where we are macroscopically with the gland. So you often see it as a triangle shape. Most of the specimens that you will get, your best chance really at seeing adrenal glands in their non-neoplastic habitat really is probably at autopsy or associated with renal specimens. But usually by the time they come with neoplasms, they tend to be quite distorted, but they do have this sort of pyramid shape with your external capsule, your cortex, and your central medulla. So within the medulla, you get your catecholamine secretions, which includes adrenaline and noradrenaline. And you can see here that's a very morphologically distinct subset, or a morphologically distinct cell population when you compare it to the more amphiphilic ovoid uniform cortical cells. So when determining cell of origin, SF1 is a fairly reliable marker for cortical cells, although not everywhere carries it. Not all labs have it. They're usually also positive for BCL2, calretinin, and melon A. Within the zona reticularis, you'll see inhibin positivity as well. And in contrast to the medullary cells, they should be negative for chromogranin GATA3 and S100. Then within the medulla, you have positivity usually for synaptophysin, chromogranin, and GATA3. The S100 is positive in the sustentacular cells, and I'll show some examples of what that looks like. But you would expect them to be negative for melanate, inhibin, calretinin at SF1. So there are other cortical cell proliferations that we're not going to cover today because they're vanishingly rare, and we only have half an hour. But just be aware that things like congenital adrenal hyperplasia, adrenocortical nodular disease exist. So these are not the sole, the neoplasms are not the sole reason for cortical cell proliferations, but they're certainly the ones you'll encounter most frequently in normal practice. So that's your adrenal cortical adenoma and adrenal cortical carcinoma. So adrenocortical adenomas are usually solitary unilateral lesions, and they can be functional, so they can produce anything that the cortex would normally produce, so aldosterone, cortisol, or sex steroids, or they can be non-functional, and just statistically non-functional adrenocortical adenomas tend to be associated with the CTNNB1 mutations. So here's a nice low-power example of an adrenocortical adenoma. So we can see here we've got our background. Hopefully you can see my arrow. We've got our normal adrenal gland, and then we have this very, very well circumscribed nodule arising from the edge of the gland. You can see immediately that it's encapsulated, it's respecting its boundaries, it's very neat. And if we have a look at the cell types, it's often quite mixed. So you can get lipid-rich cells, so where the histogenesis is from the zona fasciculata. You can get more lipid-poor areas, and they tend to be more derived from the zona reticularis. And you may see nests or cords and variation in the framework of reticulin that supports the tumour. So you can see here a nice sort of mix of different cell types, a nice mix of lipid-rich and lipid-poor. And again, if we look at the cytology, these are quite ovoid uniform nuclei. There's variation, but not alarmingly so. And there are variants of adrenocortical adenoma, and some of them can be quite uncommon. So there's an oncocytic variant, which looks very, very amphiphilic, very pink. And if that is the dominant feature in the neoplasm, then you can sort of confidently call it an oncocytic variant. There's also a myxoid variant, which I would approach with caution because they can look a little bit wild sometimes. But there is myxoid variants that lie firmly within the benign end of the spectrum. So when is an adenoma not an adenoma? And this is a little bit of a common theme in endocrine, because that distinction can be really difficult to pin down. Home and dry for malignancy is if you have confirmed metastasis or invasion of surrounding structures. Otherwise, you're sort of relying on various different scoring systems and diagnostic algorithms. And there isn't really a single system that's endorsed by the WHO, but I'm going to run through a few of them. So the most commonly used system when we're scoring adrenocortical adenomas and assessing them for malignant transformation is the Byers system. So this looks at nuclear grade, so it's the Furman grade based on the appearance of the nuclei, and you can see here the different grades of optical features. So if we're at grade 3 or 4, so essentially very irregular or bizarre nuclei, then that would score a point. If you have more than 10 mitoses per 10 millimeters squared or 50 high power field, then you also gain a point. If you see atypical mitoses, so things like tripolar mitoses or bizarre mitoses, that gets you a point. Necrosis will give you a point. Diffuse architecture, again, that's quite a subjective is quite a subjective category, but that will score a point under the Byers system. If less than 25% of the neoplasm has clear cells, that's a red flag. And then capsular invasion, vascular invasion, and lymphatic invasion all score a point. So if you have 3 or more, then that equals malignancy. And you can probably spot spot that at least mathematically or theoretically it would be possible to see capsular or vascular invasion and still not be over the line in the Byers system. Although in practice that's rarely the case because those features usually accompany other malignant features. There's a simplified and my understanding is more reproducible system called the modified Byers system, which boils it down to the more essential markers of malignancy. So a higher mitotic count nets you 2 points. Less than a quarter of the tumour being clear cells will net you 2 points. Atypical mitoses gets you a point. Necrosis gets you a point. And capsular invasion gets you a point. And if you have 3 or more, then you've got malignancy. So in terms of the weighting that is given to each feature, it's quite interesting that the presence or absence of clear cells is such a strong indicator that will get you 2 points versus necrosis or capsular invasion that gets 1 point. But this was compiled over various analyses of malignant transformation and the associated features. So there is another algorithm that you can use, which is the reticulin algorithm. So this is if you have altered reticulin framework plus one of the following. So if you have altered reticulin framework and tumor necrosis or vascular invasion or a higher mitotic count, then that is a red flag for malignancy under the reticulin algorithm. Then we have the Helsinki scoring system. So this is if you have, you get 3 points for mitoses more than 5 per 10 millimeters squared. You get 5 points for necrosis. And then the rest of it is calculated on the numerical value of the Chi-67 from the highest proliferative area. So I don't personally use the Helsinki scoring system in my own practice, but it's probably one of the more quantitative and less subjective scoring systems. So anything over 17 under the Helsinki scoring system would be an adverse prognosis, and 8.5 is your cutoff for benign versus malignant. There are other systems, so the Diagnexia system, specifically for pediatric adrenal cortical neoplasms, and then there is the Lin-Weiss-Biseglia system, which is reserved for oncocytic neoplasms. Again, just for your information, these exist and be aware of them. So here's a good example of some fairly marked nuclear variation in adrenal cortical carcinoma. And if we start to look, we can see a few other red flags here. So the clear cell component is minimal to none. We have quite large bizarre nuclei dotted around, very pleomorphic cells, variation in cytoplasm, and we also have mitotic figures that are weird and can be seen from space. This is what we mean by reticulin frameworks. You can stain that up with special stains to get a better idea of the architecture, but when it's nice and nice, regular and nested, that's a fairly reassuring feature. And then if it's sort of a little bit more blown apart, diffuse, wiped out, then it's in altered category. Capsular and vascular invasion. These are from pediatric adrenal cortical neoplasms, but I think they're a really, really nice illustration of what would get you over the line for vascular invasion. So within endocrine, we're quite strict with our vascular invasion criteria, and we need to see tumour within an endothelial lined space. And that needs to be verifiably there. Otherwise, the furthest you can go is suspicious. And often with these encapsulated neoplasms that have capsular invasion, you see this kind of mushrooming effect through the capsule, which is quite distinct even on low power. And I really do wish that all of the capsular invasion we had looked as good as this. So how are we for time? 15 minutes. Right. That is probably just about enough time to talk about adrenal medulla. And the main neoplasm of chromaffin cells is your pheochromocytoma. So these mostly synthesize catecholamines, and pheos can be hereditary or they can be sporadic. So pheos have quite variable histology. You often see a Zellballen pattern, which is just German for balls of cells. So nested balls of tumour cells in that arrangement. And these cells often have quite a granular cytoplasm. The nuclei are often quite vesicular. You can sometimes see nuclear inclusions. So this is fairly nested. It's possibly not the best in terms of Zellballen, but it's a nice view of the nuclear detail. You often get sort of visible nucleoli. The chromatin can look quite clumped or salt and pepper, and you can get these nuclear pseudo inclusions as well. You can see here as well there is a reasonable amount of variation in nuclear size and morphology. Another appreciable feature here is the granularity of the cytoplasm. This has a little bit more cytological variability, a little bit a bit less kind of distinction between the neoplasm and the surrounding parenchyma. But again, you can still appreciate this is much less nested again, but you can see slightly more nuclear hyperchromasia, slightly more variation in morphology. But again, that kind of vesicular nuclei with sort of granular cytoplasm. So the morphological spectrum of pheos can actually be quite broad. So it is quite good if in doubt at all to confirm with immunohistochemistry. So you would expect neuroendocrine markers to be positive, so synaptophysin, chromogranin, INSM1 if you have it. And most of them are tyrosine hydroxylase positive as well. Again, that's not a stain that I currently have access to, but it may be something that you have in your home labs. There'll be cytokeratin negative, GATA3 positive, and S100 or SOX10 should highlight the sustentacular cells only. And because of that really sort of hyaline granular cytoplasm, a PAS stain might show up hyaline globules. So this is what I mean by sustentacular cells. So you can see here we've got nested framework, and it's all kind of architecturally, these Zellballen are ringed off with these S100 positive sustentacular cells. So when you see that pattern of staining, and then you have the other neuroendocrine markers for confirmation within the main tumour cell population, then that's a good indication that it's a pheo and it's read the book. So there are some genetics associated. So succinate dehydrogenase mutations are associated with hereditary paraganglioma pheochromocytoma syndrome. But there are other mutations that can lead to the development of pheochromocytoma. So cluster 1 mutations, essentially, VHL-SDH, so upregulation of hypoxia signaling target genes. And then you've got cluster 2 mutations, which are mutations that result in activation of the kinase signaling pathways, so things like RET and NF1. And then your cluster 3 mutations are associated with the Wnt altered pathway. So The eternal question is, are pheochromocytomas benign or malignant? And the answer is kind of. The WHO says all patients with pheochromocytomas are currently considered to have a lifelong risk of metastasis, and therefore conceptually they're all considered malignant. But in terms of patient management, that's probably not hugely helpful. So we do need some kind of way of stratifying that risk. And there are, again, multiple grading systems that we can use. So we can do a scaled score. There's the GAP grading system, there's the COPS grading system, or we can look at the molecular aspects of the tumour. So if there's an SDH germline mutation that has a higher risk of poorer prognosis. So I'm going to just break down the main grading systems that are used. So this is your PAS score. So you get 2 points for large nests or diffuse growth that's more than 10% of the tumour volume. You get 2 points for necrosis, particularly confluent or central in large cell nests. High cellularity is, I think, quite a subjective aspect of the scoring system, and I think you really do need to see as many PHEOs as possible to get an idea of what high cellularity looks like in comparison. Cellular monotony as well, and then the presence of spindle-shaped tumour cells. Important not to mix those up with sustentacular cells, which can look quite elongated and flattened. If you have more than 3 mitotic figures per high power field, that will net you 2 points, and atypical mitotic figures as well. And then if you have extension of tumour specifically into adjacent fat, that is also an adverse feature. And then again, interestingly, capsular and vascular invasion, like huge wild nuclear pleomorphism and hyperchromasia don't score as highly. And by contrast, we also have the GAP scoring system, which is the grading system for adrenal pheochromocytoma and paraganglioma. So these are based on multiple categories. So you break it down by histological patterns. So do you have Zellballen? Zellballen are a reassuring feature. Are the cell nests getting larger and more irregular? Then you would score 1. Or if you have pseudo-rosetting, that is considered under this scoring system to be an adverse feature. And then it takes cellularity into account, so low, moderate, or high, with numerical cutoff values for each category. The presence or absence of comedonecrosis, the presence or absence of vascular invasion, and then the percentage Chi67 labeling index, and then the catechlaiming type. So if you've got an epinephrine or non-functioning type, then that is more reassuring than the norepinephrine type. So your total maximum score is 10, and the GAP category is divided into well, moderate, and poorly differentiated, with an associated risk of metastasis. So the GAP score, like a GAP score of 0 to 2, carries a low risk of metastasis. You can see once you're pushed into the moderately differentiated category, which is 3 to 6, then you start to drastically increase your risk of metastasis. So it jumps from 3.6 to 60. And then poorly differentiated in the 7 to 10 score takes you into an 82% risk. So the WHO doesn't endorse a particular system, and historically I've always used the PAS score, but I'm now starting to use the GAP score alongside it, and the new RC-Path guidelines in the UK are starting to softly favour the GAP score. So there is emerging evidence that it performs better than the PAS score. So again, it's really up to pathologist choice at this point, and also there's probably just an element of which scoring system your clinicians are familiar with. and a lot of them historically tend to be familiar with the PAS score, but the GAP score is really emerging now in popularity. So that's great. We know all about PHEOs, but just as a side note, what about paragangliomas? Because we've mentioned them in sort of syndromic context with PHEOs, and they are basically histologically and immunohistochemically indistinguishable. And the only distinction between a paraganglioma and a pheochromocytoma is where it comes from. So if it's arising in the adrenal medulla, we'll call it a pheochromocytoma. But if it's arising from extra adrenal tissue, we'll call it a paraganglioma. So you can get sympathetic and parasympathetic paraganglioma. So those can arise, so the sympathetic ones can be prevertebral, paravertebral. They can arise from sympathetic nerve plexuses and sympathetic nerve fibers. And then parasympathetic paraganglioma are of autonomic nervous system origin, so basically associated with the vagus and glossopharyngeal nerves in the head and neck. Mostly these are in the carotid body, and they're the term carotid body tumour is often used interchangeably with paraganglioma, or if they're in the middle ear, then that would be a specific entity called jugulotympanic paraganglioma based on its anatomical location. So again, this is a carotid body paraganglioma, carotid body tumour, whatever you want to call it, and you can see that morphologically this is identical to a pheochromocytoma. This is a nice low-grade looking one, at least at a glance. We've got an appreciable cell balance architecture. We have these lovely nests. The nuclei, at least on low power, don't look like they're doing anything wild, and I can't see any obvious vascular invasion here. And then jugulotympanic paraganglioma, again, looks very similar, has the same immunohistochemical pattern with your neuroendocrine markers and your S100 positive sustentacular cells. You sometimes see a little bit more crush artifact and variation in these, but again, they look identical essentially to pheochromocytomas. The only difference is the location. And I think that is our whistle-stop tour, and it has been whistle-stop, of parathyroid and adrenals, the two least loved aspects of endocrine. So here's just some resources that I share with my own trainees. I think the WHO 5th edition is just invaluable. It's fantastic, and the online one now has whole slide images as examples of most of the major entities. The RC Path guidelines on adrenal cortical carcinoma are excellent, and the ones on parathyroid as well are in the process of being updated, but are definitely still worth a look. And then there's the UK Endocrine Pathology Society. So they have multiple slide circulations available, which is hosted on the Leeds Virtual Pathology website, where you can access some really fantastic examples of, not just parathyroid and adrenal. There's a lot of thyroid as well, obviously, but the really fantastic examples of some of these entities, and the sort of get an appreciation for the variability that you can see within the same entities in this kind of field. So that is pretty much me. I hope I've kept mostly to time, and I would be more than delighted to take questions if there are any. Although I think we've only got 3 minutes left. Just going to stop sharing.
It looks like there's one in the chat if you're able to.
I will just... That's a great question. Dilshani asks, without radiological evidence, can we differentiate parathyroid adenoma from hyperplasia by histology? And the answer is no. They are histologically pretty much identical. And In the past, whenever I diagnose a parathyroid adenoma, it's always with the caveat that this should be in the appropriate clinical and radiological context. If all 4 glands are enlarged, then it's more likely to be hyperplasia, and then on the other end of the spectrum, if it's a single enlarged gland, then it would be more in keeping with an adenoma. But it's, it's histologically an impossible distinction to make. And, again, per the WHO 5th edition, there is now some emerging evidence that some syndromes do result in multiple parathyroid adenomas, which historically we've usually said doesn't really happen. So I think the distinction has become more blurry rather than less, which is not helpful for us, but so I can't see any more questions.
I think that's all.
That might
see
just
on
be
mine
it.
as well.
Well, I've had a lovely time coming and chatting to you all about endocrine pathology, and thank you so much for your attention this afternoon. It's been it's been really great fun. So thank you, and hopefully I'll be back and I can ramble on at you some more about endocrine stuff.
Thank you so much, and thank you everyone for joining, and see you at the same time next week.
Bye, everyone.
Thank you. Bye.